Good morning, friends. Welcome back to my YouTube channel, Medical Classes by Dr. Srinidhi Kumar Acharya. Don't forget to subscribe my channel and also please give your valuable comments. In the last few classes, we are discussing about approach to cough in a child. We have already completed two sessions on this, and now today we will understand the three important causes of cough, because we know that the cough in the children may be because of bacterial problem, maybe because of viral problem, or maybe because of allergic problem. For bacterial and viral, how to differentiate, we have already seen it. And what is left in the last is the allergic. The allergic cough, or which is manifested as wheeze in the infantile period, allergic wheeze or allergic coughing. So that is basically divided into three types in children. That we will see. Now, when there is a recurrent attacks of the cough without any atrophy, it means recurrent attack of the cough is there without the history of atopy, family history of allergy. Then what are the things? Now, if there is a family history of atopy is there, and child is also having recurrent attacks of the cough, the diagnosis is over. Diagnosis is a hyperreactive airway disease or atopic cough. But if there is no history of atopy in the family, but a child is having recurrent attacks of the cough, then we will call it as non-atopic type of a cough. What are the most common causes of non-atopic type of the cough? Then, the most common being prematurity. Suppose you take the history, whether the child is prematurely born, or it may be because of immature system of the child. Because we know that in the newborn period, the airways are very small. That means diameter of the airway is very small in newborn, and the development of the respiratory tract is also not up to the mark. Functionally, there is immaturity is there, and if there is also prematurity, history of premature baby or low birth weight baby, then this may be a cause of a non-atopic type of a recurrent attacks of cough. Okay, so this child is having prone to repeated wheezing. Sometimes you may also find the history of, suppose a child with a birth asphyxia, okay, child with the intervention during the time of the delivery, child with the left to right shunt, or child with the gastroesophageal reflux disease, child with the fistula, that is tracheoesophageal fistulas, aspirations, okay, sometimes chemical aspects. So these all things may lead to wheeze or cough in a child without the history of atopy, and such things are called as a non-atopic type of allergic disorders in childhood. And we will usually call usually such children such kids or infants will frequently get the attacks of the wheezing. Therefore, we will call them as transient wheezers. Okay, this group is considered under transient wheezers. Transient means for a some time, for a stipulated time, they will have the wheezing, and this is happening repeatedly. Now, approach to what is the approach to recurrent and persistent cough? Suppose if the persistent cough or recurrent cough is there, what should be your approach? Now ask whether cough is there with a fever or without fever. First question. And if the child is having fever along with a cough, then definitely there is infection. Now we have to decide whether this infection is viral or bacterial. And we know how to decide whether it's a viral infection or bacterial infections. 5 questions are the like mode of onset, interfebrile period, response to antipyretic, then what is the state of the fever on 4th and 5th day, okay, what is the rhythm of the fever, and these 5 questions are there. By that you can very clearly identify whether it's a bacterial fever or viral fever. And if it is viral or bacterial, and if it is recurrent, then what we have to do? If it is recurrent and it is viral, suppose it is viral and it is recurrent, then do nothing. Do nothing, because viral fevers are common in children, and do nothing, just assure the patient. And if the patient is not satisfied, just look into the growth chart. And if growth chart is normal, okay, height, weight is gaining properly as per the age, growth velocity chart, then assure the patient there is nothing, simply give the symptomatic treatment and send back. Now, why a toddler get recurrent viral infections? Because I told that recurrent viral infections are quite common in the toddler age group. Why? Because the protection, when each time the infection takes place, viral infection takes place, the protection is offered by the cell mediated immunity. And cell mediated immunity is quite immature in children. Okay, so toddler get repeated attacks of the viral fever. With each viral infection, the cell mediated immunity, as it is immature, it would not produce the expected sustaining cell mediated immunity. And every time the virus goes on changing its structure, the facial expression, and goes on mutating. So immune system will be get confused, like for example influenza, etc. This also happens in adults also sometimes with immuno compromised state patients. This can also, but in children it do happens. What? Why? Because the cell mediated immunity is not so mature in children. It is quite immature. Therefore, each time when infection occurs, the cell mediated immunity is not able to produce the expected level of the immunity. And because of this, what happens? The virus each time goes on changing its structure and also facial expression and goes on mutating. So now the immune system is get confused and there will be recurrent respiratory tract infections. Oh, this is, I told, if it is viral, what we have to do. If it is viral, just look at the growth chart and confirm all these things and assure the mother. Suppose recurrent fever is there and cough is there. Recurrent cough and is there and fever is also there. And it is bacterial. Cough is bacterial now. Now the cough is because of the bacterial origin. Now decide whether it's upper or lower. Repeated upper respiratory tract infections, when it is there, as we have seen already, viral infections are the most common cause, or allergic manifestations are the second most important cause. Repeated respiratory tract infections with the normal growth chart, it is safe in the both conditions. This is the way to assure the parents. Okay, repeated respiratory tract infection is taking place, but you know that either it is viral or allergy. Then again, go to the growth chart and show the growth chart to the parents and assure them, let this infection happen, nothing to do, nothing to worry because growth chart is normal. But if the repeated respiratory infections are there, but it is because of the bacterial. Okay, infection, repeated respiratory infection means repeated upper respiratory infection is there. The cause is bacterial. What to do? The most common causes which cause bacterial upper respiratory infection is with cough. One is deviated nasal septum, child with a history of a deviated nasal septum, any other obstructions, adenoids, tonsillitis, rhinosinusitis or sinusitis, etc. These are the most common causes. Therefore, if cough and fever is there with the upper respiratory infection and cause being bacterial, then this point has to be seen. This is called as background causes. We call them as background cause. Already child is having some background cause because of which he is getting bacterial infection. Otherwise, bacterial infection will not occur so easily. Okay, so as I told, bacterial infection always occurs localized way. So where there is actually Kavaigunya, or in Ayurveda what we say Kavaigunya, only there it goes and causes a problem. Tonsil is weak or tonsil is enlarged, there will be infection. Adenoids, there will be infection, or some DNS-like condition, some other congenital malformation of the respiratory tract, sinusitis because of some improper drainage and all, structural problem again, improper drainage and all, sinusitis. So these are the most common causes that you have to think when upper respiratory infection is there and causes bacteria. Now, why there is lower respiratory infections? So upper respiratory infection cause being bacterial is over. Now, lower respiratory infection cause being bacteria. What are the cause? Why there is lower respiratory infection? Just like recurrent pneumonias. Lower respiratory infection means recurrent pneumonias. Repeated lower respiratory infections requiring IV medication and hospitalization should be considered as seriously. So when you call any infection as lower respiratory infection, when a respiratory infection, when it requires IV medications and also it requires hospitalization and IV antibiotics and all, and that is usually called as lower respiratory infection. It is not simple upper respiratory infection. It is considered as lower respiratory infection. So he will have commonly three problems. When such lower respiratory infection, bacterial, when it occurs, it has three problems. One is it is localized to the one particular anatomical area. Okay, so it is localized to anatomical. Suppose when pneumonia occurs, The bacterial infections are usually lobar pneumonia. It is pertinent to one particular lobe or one particular lobule. Okay, most of the time they are localized. They are not generalized as occurs in case of viral. And there may be some congenital malformations. For example, cardiac disease. Congenital cardiac disease are one of the most common causes for lower respiratory bacterial infections. Or there is a low immunity, generalized low immunity. These are the three main causes why actually or how the bacterial infection occurs, especially in the lower respiratory tract. Or there may be sometimes functional abnormality like ciliary dyskinesia, cystic fibrosis, etc. condition where drainage is not proper. So these are some of the most common conditions where bacterial infection occurs in the lower respiratory tract. Now, we know that bacterial infections very rarely leads to cough, but viral infections always leads to cough. Okay, so there is no cough receptors in the tonsil, pharynx, and the throat area. This we have to know. See, therefore, when tonsillitis, there is only throat pain. Bacterial tonsillitis, there is only throat pain. There is no cough more because in the tonsil area there is no cough receptors. In the pharynx area also there is no cough receptors. Okay, it is because of the massive destruction of the mucous gland. We will have some irritation in the throat and it feel like cough. Actually, in the throat area, pharynx area also there is, or in the throat area and in tonsillar area there is no cough receptors. So any bacterial infection which is occurring in these three areas will not cause much cough. But cough receptors are present in the larynx to bronchi. Starting from larynx to bronchi, the cough receptors are present majorly. So cough reflex is carried through the vagus nerve. So pharynx is not carried by the vagus. We know that pharynx is the muscles of the pharynx are not supplied to the vagus. They are supplied by some other cranial nerves. Okay, tonsillitis patient usually don't cough. That also we know. Okay, usually viral pharyngitis causes the cough due to the irritation, as I told earlier, but not the bacterial pharyngitis. Now, bacterial tonsillitis, there will be no cough because there is no cough receptors in the pharynx and tonsillar area. This is quite repetition. Okay, it may be viral, which is causing the cough due to disseminated spread. In the viral, always there will be a cough. Severe cough will be there because it goes on destroying everything. And cough receptors are also present. So that's one thing is very clear. Where actually cough receptors are present? Cough receptors are present starting from larynx to the bronchus or tracheobronchial junction. As they go downwards from the tracheobronchial junction on the right and left bronchus, the number of cough receptors goes on decreasing, and when it reaches the lowermost part, like respiratory bronchioles, there is no cough receptors. Therefore, a disease of the alveoli will not cause the cough. There may be breathlessness. There will be breathlessness. Now, clinical relevant anatomy of the respiratory system. What is that? Cough is not a predominant symptom. Suppose cough is only mild cough. So this is commonly seen in the case of pleura disease, lower part. I told because there is less cough receptors as you go down. Pleura, lower part, bronchioles. Mild or no cough with breathlessness will be there. Cough without primary respiratory disorder. There is a cough, but there is no primarily respiratory disorder is there. No respiratory involvement is there, but still cough is there. Then what do you think? Either it may be because of cardiac, or either it may be because of GIT. It may be because of neurological problem. It may be because of irritation of the cough center by the tumors which is present in the brain, some parasitic infections, phrenic nerve irritation, or sometime, yes, some of the phrenic nerve infection. Now, respiratory disease without cough. Sometimes there is a respiratory disease is there, but there is no cough at all. This is also possible. As you go down, there is no cough receptors. Only breathlessness will be there. So interstitial lung disorders, you will have actually the respiratory disease without cough. Now, severe cough without chest pain. Severe cough is there, but there is no chest pain. Okay, so this is seen in case of cough variant asthma and upper respiratory tract infection. In the upper respiratory tract infection, we have not yet reached the chest area itself. Then why there will be chest pain, isn't it? So severe cough with the normal chest X-ray, it's a disease of airway. Severe cough is always indicative of airway disease. Okay, airways are not clearly seen in case of X-ray. You can't find anything about the airway in the X-ray. So whatever may be the severity of the cough, if you go for X-ray, you find nothing in the X-ray. You find something in the X-ray when only the disease is of lung parenchyma. Okay, so airway disease have abnormal X-ray where it is if the part of the lobe has undergone the collapse or emphysema, etc., then abnormal. That is in the lower respiratory tract in the lung parenchyma. Only you will have abnormal X-rays. So usually patients say when he is having severe cough, and doctor iska ek X-ray kara dijiye. Okay, you know that it's a severe cough. Nothing will come in the X-ray. ओके, देन पेशेंट से हमने एक्सरे भी करा दिया और फिर भी जो है कुछ नहीं आ रहा है, सो कुछ नहीं आएगा. द रीजन इज द कफ ऑलवेज इंडिकेट्स द एयरवे डिसीज. So how does one cough? Okay, how a patient will going to cough? So first there will be deep inspiration, then this build up the pressure, and before expiration the glottis is get closed, and then the pressure further increases, and glottis suddenly gets open. Air comes out with a loud sound. This is what is told by Charaka. अधः प्रतिहतो वात ऊर्ध्वश्रोत समाश्रितः उदाना भावमापन्न कंठे सक्ते ततो रसिः आविश्य शिरसा कणि सर्वाणि च प्रतिपुरयन् अभञ्जन् अक्षिपं देहे हनुमद्य तथाक्षिणि शुष्को वा साकवो वा कसनात् कासमुच्यते. Exactly same thing. So where child has a cause for the cough but can't cough. So this is how the child cough. Now sometimes child has a cause for the cough but he cannot cough. What are such situations? Actually, he has got some cough causes for the cough, but still he is not coughing. You find all such situations also sometimes. For example, child with a delayed milestone, child with mental retardation. Okay, cough metabolism, sorry, rather, cough mechanism is not developed and coordinated because of developmental delay. So, where although having cause for the cough, child is not able to cough. Again, one more cough cause is there, but child is not able to cough. That is vocal cord paralysis. Okay, so what you say about the newborn cough? Mother usually come, my child is 10 days old baby, my child is coughing, coughing, coughing. So what do you say about that? A newborn cannot cough because, as I told earlier, coughing is a mechanism which requires a lot of coordination. It is not possible by the newborn baby to do all this coordination because newborn is structurally and functionally both immature. Okay, there is no myelination of the nerves which is required for the coordination of the cough reflex in the newborn baby. So cough in a newborn is not possible. If it is coughing, then definitely it has got some other severe problem. Okay, so newborn cough is mostly misunderstood by the mother because of some other sound which is coming from the upper respiratory tract. It may be because of the thymus gland or some other secretions, etc. Now look at some other points regarding what is the choice of cough syrup. Actually, no cough syrup will relieve the cough. This is a fact. So many cough syrups are available in the market, but no cough syrup can relieve the cough because cough is a protective phenomenon. Okay, suppression of the cough is not a good thing. As it is a protective phenomenon, it should not be suppressed. So cough is a protective reflex and should not be suppressed. Even a drop of the water when enter inside the trachea, there will be a cough. We will have a cough. So, but what we have to do is, we cannot leave the cough as it is. We should try to relieve the discomfort caused by the cough. That should be relieved. Suppose cough is there and child is not able to sleep. Now this is a discomfort. When the cough is there, because of cough, child will have chest pain. Okay, cough is there because of cough, the bronchospasm is increased. Now this has to be treated. Not exactly cough should be treated. Cough should be suppressed. Now child cannot sleep. You can go for mild sedatives. Child chest pain is there after coughing. You can go for muscle relaxants. Okay, chest pain is bronchospasm is there after coughing. You can go for some of the bronchodilators. So this you can try, but cough itself should not be suppressed. Now, what are the different choices of cough syrup when we say expectorant? Expectorant, expectorant in the children or newborn should not be used because they don't know how to expectorate the sputum out. This is very important thing. The newborn and infant don't go for expectorant. Although it will break the mucus plug, child don't know how to put it out. So it may lodge there itself in between and cause the obstruction. So parent may say that he omits the sputum in the stool. He omits the sputum, and in the stool also the sputum is going on. And it is coming from the stomach and not from the airway. So when the abdominal pressure increases too much, there will be vomiting also. So this is about the expectorant. What about the mucolytic? Breaking the mucus plug. Mucolytic will liquefy the mucus, and this is required when there is an abnormally thick mucus plug has been formed, as in case of cystic fibrosis. But when there is no cough in children itself, how he will be coming out although it is liquefied? Child is not able to do the cough mechanism itself, newborn or infant, early infant. So how he can put the sputum out? So there is no role of a mucolytic also. Okay, so nowadays a wide spectrum of cough syrups are used, which are totally senseless. It contains expectorant, it contains mucolytic, everything it contains. and it is given in the newborn also. But newborn don't know how to cough itself. Then what is the use of this expectoration and the mucolytic? Okay, it don't, once there is no coughing itself, whatever expectorant mucolytic you use, it is not able to put out this broken sputum to outside. So this is totally actually senseless. Now look at another important thing, that is wheezing as a symptom. So this we will continue in the next class. Don't forget to subscribe my channel. Please also give the comments in the comment box and keep watching, and we will meet in the next class and we will discuss wheezing as the main symptom. Thank you very much.